I am a clinical research fellow, and my day-to-day job is to look after patients who have treatment within a clinical trial. And I will discuss about the new drugs that we are working with, the results from the trials, the side effects, how we manage the side effects. And I will also discuss just slightly a bit the tissue bank, but Jane will help me as well. And I'll also discuss a bit about service specification and how our multidisciplinary team works. So these are Robin Jones disclosures. I don't have any disclosures. I will discuss about these 3 new drugs. Avapritinib, developed by Blueprint Pharmaceuticals, Ripretinib, developed by Pdgfr Pharmaceuticals, and cabozantinib, developed by Exelixis. These are all tyrosine kinase inhibitors, part of the same large family of treatments that you know more about, as in imatinib, sunitinib, and regorafenib. So I will touch base about each one of these clinical trials, results, and side effects. I will start with the avapritinib, was called before Blue 285. The initial trial compared 2 doses, 300 milligrams and 500 milligrams once daily, for 2 populations of patients. Patients who had already received all the available treatments, the other 3 drugs that I have mentioned, and patients who have a specific mutation in the Pdgfr alpha exon 18. The arms were quite balanced. It is important to say that even in the arm of patients who have received more than the 3 lines of treatment, there were patients with Pdgfr alpha mutation, and that it's important because of some of the results that I'll show you later on. So, as I told you, the arms were quite balanced. Most of the patients had metastatic disease. The tumor dimension is on the last 3 rows, so less than 5 centimeters, tumors between 5 and 10 centimeters, and a smaller proportion tumors more than 10 centimeters. And this graph actually shows the response of patients with Pdgfr alpha mutation. And I will explain you what this means. All the bars that go down means that a patient has responded, which we see is a large proportion of these patients who have received avapritinib in the Pdgfr alpha exon 18 mutation. Only 2 patients who did not have a reduction of the tumor, but all the rest, which is 95%, had a tumor reduction. This means that avapritinib is very effective in Pdgfr alpha exon 18 GIST and has recently received FDA approval for this population of patients. This is the duration of response, so how long the patient will respond on the avapritinib. What we see here is that the median has not been reached yet, which means that 50% of patients, they are still responding at the time, more than 50% of patients are still responding at the time that this analysis was presented. PFS at 12 months, which means that patients who did not progress at 12 months, 1 year, was 74% in this population, which is an incredible result. Overall survival at 12 months, which means the patients that were alive at 12 months, were 90%, which is, again, a very good success response. Now, in the other population, in the other arm of patients, not necessarily with Pdgfr alpha, but with all mutation in their GIST, that have already received 3 lines of therapy, the imatinib, the sunitinib, and regorafenib, have received the avapritinib as a 4th line or more. We can see the bars that go down showing the patients who responded, quite less than the patients with Pdgfr alpha mutation, but still 22% of these patients have responded. 70% amongst those patients were having a Pdgfr alpha mutation. The others were having different type of mutations. Again, for this population of patients in 4th line or subsequent lines of avapritinib, the median PFS was 3.7 months, The median overall survival was 12.3 months. So patients have received avapritinib fourth line and later have lived median 12.3 months. The side effects, and I'm a specialist in side effects because I see everyday patients on avapritinib, and we have to manage the side effects. First of all, the neurocognitive side effects, and this includes memory loss, concentration problems, balance issues. It's really important to catch the side effects very early. Whenever we see there's some changes in the patient's cognitive status, they become more forgetful. They say, oh, I can't do the crosswords anymore as before. I can't read as before. Then we have to be very careful. And if we believe it's the treatment, the drug, who causes this, we either take a break of the treatment or we reduce the doses. We definitely don't let this become too serious side effect. We usually request CT scans or MRI of the head. In most of the cases are normal, which means that we have to advise patients, take a break, come back in clinic in about a week or 2 weeks, see how you're doing. If you improve, then we'll have to reduce the doses. If we don't see an improvement, we'll probably have to stop the drug. The most adverse events in the trials were grade 1 or 2. And it was a higher incidence of side effects in the higher dose arm, 400 milligram, versus in the 300 milligram dose group. Now, the recommended dose is nowadays 300 milligrams. Most patients were able to remain on treatment after we have done the dose modifications when needed. About 8.3% of patients discontinued due to the treatment-related toxicities, and in a small number of cases of 2% discontinued because of the neurocognitive effects. And this was about avapritinib. There are other side effects that I want to mention, as in periorbital edema, so the patient that have swelling of their eyes, hair discoloration, the hair will go gray. Sometimes the liver function can be a bit altered, and we see this on the blood test that we do at every visit. I will go now to the next drug, which is the ripretinib, previously known as DCC-2618. And the trial initially done for this drug in a phase 3 called Invictus was comparing the ripretinib with placebo. Randomization was 2-to-1, which means 2 patients into ripretinib and 1 into placebo. The CT scans are usually sent to Central Radiology Review, which is the company. And if they consider that the disease has progressed, then we have the option of crossing over, which means the patient that were having the placebo can go into the ripretinib. The patient who would have the ripretinib, but they did progress, they can go into a higher dose of the drug ripretinib. Initially, we started 150 milligrams once daily. And in this trial and in current practice, if we see progressive disease at 150 milligrams once daily, we go to twice a day. So 150 milligrams twice a day. The patient also had the choice of continuing the same dose if they felt that this is the dose that they accept, they tolerate, and they're happy with the disease progression by the central review. Or the patient could discontinue the trial if they didn't want to continue anymore. Again, the patients in the placebo arm, they could go into the ripretinib or could stop the trial and go into different treatment options or different trials. The baseline characteristics are quite balanced in this trial. So ripretinib, 85 patients, placebo, 44 patients, median age 59, 65. Male, female were quite equal, so keep in mind that on the ripretinib column, the numbers should be double than on the placebo column, just because the number of patients were double on the ripretinib arm. Number of previous therapies, 3 or more than 3, 4 in subsequent lines. patients would have all sorts of mutations, KIT, Pdgfr alpha, wild type when there is no KIT nor Pdgfr alpha mutation, or we didn't know the mutation status at the time of this enrollment. This slide shows how well the ripretinib works compared to placebo. And you'll see on the purple line here, the patients would have progression-free survival at 6.3 months versus 1 month in the placebo arm, which means that 50% of patients had 6 months of no disease progression versus 1 month in the placebo arm. The hazard ratio is 0.15, which is a 85% risk reduction of disease progression or death with ripretinib when compared to placebo. The overall survival also had a very good benefit, 64% risk reduction of death compared to the placebo arm. The median overall survival was 15 months in the ripretinib arm versus 6.6 months in the placebo arm. Again, side effects, and I'm very mindful when I discuss about this trial with the patients because I want them to be aware of the side effects of this drug. And we have seen hair loss. Sometimes it's difficult to accept hair loss on a tablet, on an oral tablet for a GIST patient. Fatigue, nausea, tummy pain, constipation. We have seen quite a lot of patients complaining of muscle pain, and they feel like it's the same sensation they had on imatinib. So patients who had muscle pain on imatinib, they feel they have muscle pain on ripretinib as well. It's quite an interesting finding. Diarrhea as well. I've noticed photosensitivity, patients going out covered and feeling, oh, I had like a sunburn on my hand, but I didn't go into sun, I wasn't exposed. So it's really interesting, and it's really important to hear the patient's toxicity and how they feel on this drug. Next, I'm going to talk about the other drug, the third drug, called cabozantinib. This was a phase 2 trial, which means that there was no placebo arm. All the patients received cabozantinib in this trial. And they looked at progression-free survival of 12 weeks. So how many patients had stable disease or their disease has progressed at 12 weeks. And very interestingly, so there were 50 patients in total enrolled, but 41 were evaluable, which means that 41 had scans on time, they finished the first cycle on time. So when we do analysis, we look at the evaluable population, okay? And these were 41%. And 24 patients of 41, which is more than half of them, had a stable disease at 12 weeks, or even response at 12 weeks, which is very encouraging. So this trial was a phase 2, and I hope they will open a later phase trial when they compare either placebo or to another drug. The cabozantinib comes with some side effects, a bit more than the other 2 drugs, and we have more experience of cabozantinib in another type of cancer, for example, in kidney cancer. In these tables are presented the most frequent grade 3 or 4 side effects, which are the most serious side effects. And when we encounter one of these side effects, we have to take a break of the drug, we have to interrupt, or even to stop it, okay? And I will just mention some of this from the table. You can see anemia, lymphopenia, so low lymphocytes, low white cells, low neutrophils. Then lower down we have low phosphate, increase of the gamma GT, which is a liver enzyme, low sodium or low potassium. And it's really important that patients have frequent blood tests so we can catch the side effects on time and offer treatment in case we see this. Supplements of potassium, supplements of sodium, take a break, or so on. We also seen low calcium, low magnesium, or high magnesium in some cases, low calcium, again, high calcium and low potassium. So that's why we want to see blood tests every time we have a patient on a trial. And sometimes can be a bit too much because our patients are coming in the morning, they have the blood test done, takes 2 hours or more to have the results, and only after that they get the drug. And sometimes can be a time of frustration for the patient. They want to come and go. But just for this safety criteria, we have to make sure that blood tests are okay, the patient's vitals are okay, and they are doing well on the drug so we can continue on the trial. Now, I'll just mention very quickly about the National GIST Tissue Bank, and Jane will help me more about this. It was initiated in 2014 in Newcastle. The aim was to provide high-quality GIST samples so they can be used for national and international research studies. Now it is located at the Royal Marsden. This is the, in that image is the Center for Molecular Pathology, which is localized in Sutton. We use fresh frozen paraffin tissue and blood sample as well. Has received ethics approval and a Human Tissue Authority research license to collect samples nationally and internationally. Also, we have an ASOP agreed to make tissue donation, if you want to add something now.
Okay. Yeah, basically the tissue bank, obviously we started it some while ago, the idea being that we wanted to try and help researchers and stimulate GIST research, because any researcher looking to do research needs the raw materials to do that work. And when I first got involved, a bank like this didn't exist. So it would be quite off-putting to a researcher if they at that time decided they wanted to do GIST research and then they couldn't find any of the materials to do that. So the bank as it is has been going very well. It's been going for 5 years. The ethics approval has just been renewed for a further 5 years. That's no mean feat, actually. It's quite a lot of work involved in getting renewal of ethics approval. But I suppose the gratifying thing is that having got that tissue bank in place, we've actually now got researchers who are applying to the bank for tissue for their research. And these are 4 of our researchers so far that have had tissue. We've got Dr. Ruth Casey, Dr. Olivier Giger in Cambridge. We've got Dr. Karen Sissy up in Sheffield. We've got Dr. Henry de Brits up at the Beatson in Glasgow. So really this is just to show you how things are progressing, no more than that. You know, if you should be preparing for an operation, then you know, there's no reason why you shouldn't donate tissue. It's the tissue that's collected is the tissue that's in excess to any diagnostic samples that are taken for your care, and it's usually the stuff that will probably get thrown in the bin. So we'd rather have it so that it can be available to researchers. So the way to go about telling us is to make sure you tell us hopefully quite a distance in advance. A couple of weeks is ideal, especially if it's a hospital where you're having an operation that we haven't you know, dealt with them before. I can see at least one patient in this room that's donated tissue to our bank, and it's a situation where once obviously the samples are issued to researchers, we need to make sure they're replenished. So it's an ongoing process, and that's it really. Just to tell you where it is, it started from nothing and now it exists, and we just need to make sure that it keeps going. So thank you.
Thank you.
Can I ask a question?
Yeah.
I wasn't asked about donating.
Oh, right. Yeah,
So-
I understand.
So
So it's not.
general thing or what?
It's not, what tends to happen, every hospital that's doing operations, they will usually ask you to sign a standard form within their hospital about, are you willing to have some of your tissue used for research, and that's just a very broad brush consent. The consent for the National GIST Tissue Bank is very specific. It isn't standard practice in every hospital. So if you decide you'd like your tissue to go to research, you do need to make contact with us to get the wheels in motion to do that. You know, it's not a difficult process. either I or the tissue bank management team will send you a consent form, and you need to obviously fill that out. It's not difficult. It's your initialing bits that you agree to, etc. You send it back, and once we've had your confirmation of consent, we would then engage with the hospital, the surgeon, the pathology department, and Just Support UK, where the tissue is being collected from a hospital that isn't the Marsden. Just Support UK funds the courier service that takes it's a specialist courier service that takes the tissue from wherever it is to the Marsden. So sorry about that, but unfortunately that's just the way things are. I don't know how we make it that every hospital in the country that's doing a GIST operation has this consent process in place. We probably don't need every hospital to have it in place, because obviously we're hoping that the Marsden operations will replenish quite a lot of the samples. If the operation's not happening at the Marsden, but you happen to be a Pdgfr GIST or a wild type GIST, that's the ones that we're probably keener to collect from all over the country, because believe it or not, the exon 11 ones and those sorts of ones are probably more commonly available, so we perhaps don't need to spend so much effort in collecting them from anywhere other than the Marsden. Does that make sense? Does that answer your question?
It does, yeah.
Okay.
It's late though, but...
Okay.
Thank you.
Right, thank you.
Thank you. Okay, so I'll continue with my presentation. In the last couple of minutes, I'll just discuss about the National Service, Sarcoma Service, and how our MDT, our multidisciplinary team, works. So NHS England has published on their site a Sarcoma Service guidelines. So they commission the sarcoma services for all the ages. Why do we need to centralize sarcoma care? So you already know it's a very rare cancer. Soft tissue sarcoma, which is a broad term, incidence is 5 per 100,000 a year. There are 1% of all the cancer cases in the UK, 2,400 cases per year of sarcoma. They are extremely heterogeneous, so within the soft tissue sarcoma umbrella, there are really 100 different types of soft tissue sarcoma, and they're all behaving differently. So we need an expertise in all areas of management: surgery, chemotherapy, radiotherapy, diagnosis. And this requires considerable training, infrastructure, and cumulative experience. It's really important to have an early and appropriate investigation, and then the treatment may be beneficial if we catch earlier the cancer, as we know. So, National Institute for Health and Clinical Excellence published in 2006 this guideline on the improving outcomes for people with sarcoma. And actually what they advise is early referral to a specialist center, diagnosis by a specialist team, centralization of care, and a multidisciplinary team. So all patients with a sarcoma, they must be managed by a sarcoma multidisciplinary team. They need to be referred to a designated diagnostic center for the diagnosis. The sarcoma diagnosis must be reviewed and confirmed by a sarcoma expert pathologist. Surgery is really important, and the sarcoma surgery needs to be performed by a properly skilled surgeon with experience in sarcoma management. And usually this comes through a sarcoma MDT, where lots of surgeons, specialists are present there. And this is a specialist center means that they have more than 100 new cases of sarcoma soft tissue per year, more than 50 new bone sarcoma, and 25 or more of retroperitoneal sarcoma. This is the scheme of a multidisciplinary team, and we're happy to have this multidisciplinary team at the Royal Marsden. It's really important to have all these links into it. So pathologists and radiologists to confirm the diagnosis of sarcoma, a surgeon, and it's really important because the surgery is the only curative modality in a sarcoma. It needs to be done by a skilled surgeon. Radiation sometimes can help with the local control or even palliate symptoms such as pain, compressions. Chemotherapy can be helpful before or after the surgery if it's early diagnosis. Again, we have access to a palliative care team and specialist nurses, physiotherapists, and other specialties that are involved. Sometimes we manage sarcomas in conjunction with other MDT, site-specific MDT, for example, gynecological sarcomas. We present these cases in the gynecological MDT for our colleague surgeons. Head and neck sarcomas, again, managed with head and neck surgeons. Chest wall intrathoracic, and we refer our patients to the Royal Brompton Hospital. They are specialists in thoracic surgery, skin, neuro, or pediatric sarcoma. Now, the guidelines specify that all sarcoma patients need to be referred to a specialist MDT, and because for sarcoma in GIST, we need specialist imaging. For bone sarcoma, we can use plain X-rays, and this help with the diagnosis. But for soft tissue sarcomas, we need MRIs. We use CT scans for staging, just because the soft tissue sarcoma, they tend to spread to lungs, first of all, so we do CT scan of the thorax for all our patients with soft tissue sarcomas. CT, MRI, PET-CT, they can be diagnoses. So in conclusion, I presented you today a number of new drugs that are effective and they're in development for the treatment of GIST. We have briefly discussed about the National GIST Tissue Bank and about sarcoma service specification. This is the team of sarcoma team at the Royal Marsden Hospital: surgeons, pathologists, radiologists, medical and clinical oncologists, specialist nurses and physiotherapists, clinical trials team, and we work very closely with the Institute of Cancer Research to help them with the research. And thank you very much for your attention.
Okay, thank you very much. I'm sure there are some questions in the room, so if you have a question, raise your hand. Give us a second to get this microphone to you so that the question can be heard on the video, and then hopefully we'll get some answers. So, are there any questions?
Oh, some, yes.
Hello, thank you for that. I have a question about drug testing, and I'm just trying to understand how GIST patients can be given placebos. Is it simply that the first 3 lines of treatment have failed, and if the drug under test shows some positive results, then the placebo patients will be transferred to the drug?
So yes, most of the trials, they have this option when, if the patient has received placebo, they can, when the disease has progressed, they can go to the arm with the drug, with the active drug. Most of the late phase trials, or phase 3 trials, they offer these options to patients. Why do we compare to placebo? Because it's important to know if the new drug is really doing something, or is just how the disease would normally progress. So we need to have that clear separation. It is the drug who's doing something, and it's not just the natural history of the disease. And sometimes can be difficult when we offer the trial to a patient, telling them you might go into the placebo arm and not have a treatment. And I understand the frustration. What we do is we closely monitor, because the patient that go on the placebo arm, first of all, we don't know. So it's a controlled placebo arm. That means that neither the doctor or the patient know which arm they go into. But if they get the placebo, they always have CT scans at the same time as the patients who don't have placebo, which means we very closely monitor these patients, either placebo or on the active drug. And we know if at some point the tumor has progressed, then we unblind, which means that we know if the patient was placebo or not, and then we offer to go on the active trial. But it's a really, really good question. Yeah.
You're right, it sort of sounds like a lottery, doesn't it? Which one you may or may not be on.
Yeah.
So it is important to understand that it's picked up if it does progress, and then you're given that treatment. So that's a good question, very important question.
Yeah.
Any other questions?
Yeah, can I go on to what this gentleman said?
Yeah.
Doctor, who would go on a trial drug if they weren't 100% sure? You understand what I'm
Yeah. I know. Yeah.
getting at? I mean,
Exactly.
why would I, for instance, go on a trial drug when I think I might get placebo?
Yeah. Well, the way I sell it, and it's not actually selling, is these trials are taking place way before the drug would be available to the broader population. Which means that even if you get placebo and you at some point will be crossed to the other drug, you'd have access to the drug way earlier than most of the rest of the population, because it takes roughly about 5 years from a trial has been started to when we have the final results, so we can offer the drug to the population. Yeah, but it's, again, a very good question.
I just, no, it's relevant to this.
Yeah, sorry.
Would it not be perhaps kinder
Yeah,
to offer a trial where if a patient's already on, say, regorafenib,
yeah,
but is showing signs of being less effective, to keep them on regorafenib against the new drug, or whatever drug they happen to be on, so that they've still got some control of the tumour? Would that not make more sense in terms of trial setup?
and it's always one of the options. So I think I have mentioned about if there is disease progression, the patient always have the option to continue on that particular drug because they did well, they tolerated well, they didn't have many side effects, and maybe the progression was very, very slow. So they always have this option that we discuss with them, absolutely.
Moving on from that, I'm sure this is a question that a lot of people in the room are thinking. How do you get onto the trial?
Good question. So it's your local oncologist who would refer you to the Royal Marsden or any other hospitals who have trials. So that means that you have to discuss closely with the local oncologist, and if you feel sometimes it's a long distance between a local hospital and the Royal Marsden. So this is something we keep in mind for patients who are coming from Scotland, coming from north of England or Wales or so on. The travel can be expensive, can be tiring, can be long. It takes a lot of your time. Some of the trials require you to come every week or every 2 weeks to the Royal Marsden, so that's a lot of traveling, especially in the beginning of the trial when we don't know how every patient will react. But if the other 3 available drugs are failing, then and if you are willing to take part of the trial, then talk to your oncologist and just send a letter, an email, Dr. Jones there, Dr. Jones email, or just the Royal Marsden Sarcoma email, and do and have a referral to us.
So the follow-up question to that is, how does the oncologist know there's a trial?
So for some new trials, Dr. Jones usually contacts the oncologist to make them aware we have a new trial opening. They can always find the open trial on the clinicaltrials.gov or Sarcoma UK.
Just Support UK.
And Just Support UK, sorry.
Just Cancer UK, I should say.
Cancer UK. And they always show the open trials enrollments in the UK, actually, for your type of cancer. So they're always available on the internet online. They should always be available there.
So part of what's come out of that to our audience here is that if you are either failing on a drug or if you're on the 3rd line and it's not reacting for you in the way that it should be, and you've seen your oncologist, maybe before you go to your oncologist, speak to us, because invariably we will know that there are trials around so that we can at least advise you that when you're sat in front of your oncologist, you can ask them about it. Because, as much as Robin and his team would try and get all the oncologists to know, there may be some that don't know. So use us, use the resource of our website and our phone line, etc., to find that information.
Yeah, you mentioned the 3 drugs.
Yes.
So I was interested to understand, I think you said the first drug has now been approved. What about the other two drugs? Where are they in terms of fears of getting them approved for use?
Yeah, so the first drug was approved in the United States for adult patients with Pdgfr alpha mutation. We at the Royal Marsden, we have a compassionate access program for the avapritinib and the repurposing for the first two drugs, which means that, again, if the oncologist believes that you'd go on a further line of treatment, they would refer you to us, and then we request access from the company, from the pharmaceutical company. So it's not the NHS who's paying for these two drugs, it's the company who's developing these two drugs and offers us access. So we have that open program, compassionate access for the first two drugs. Now the third drug, as I mentioned, was only studied in a small trial. So we need more data, we need a larger trial where that drug is compared to either placebo or to another trial, to another drug, before it can be offered as a compassionate access drug. So we need more research on the third drug.
In terms of avapritinib, the first drug, the NICE appraisal process has just started for that drug, so it's not naturally available as a treatment option through the NHS at the moment, but one hopes that by the time the NICE approval process has happened, let's hope it's a positive outcome, because it's shown an awful lot of promise, isn't it?
Yeah, indeed.
All my results came back 0. I'm on nothing at all, so I'm only on scans. I just had my first scan. After listening today, am I in limbo waiting for something to turn up before I get anything, or should I go back to my oncologist and find out more?
So you haven't got any evidence of disease?
No.
Well, you shouldn't be on anything then if there's no evidence of disease.
My tardigrade, everything was 0, so I'm now wondering.
If you haven't got any evidence of disease, there's no need for you to be on any drugs, unless you've got a very high risk of it
Only
coming
for the
back.
size, I have a 52% risk, so I'm wondering then, are we waiting to see something and it's...
It's usually, well, I mean, obviously every patient's individual, but it's usually watch and wait in that situation.
Yeah,
No evidence of disease is a good place to be.
it's very good.
Yeah.
Yeah,
Absolutely.
it's very good.
Yeah, I've been 10 years like that. I'm still
Such-
sad because...
Yeah.
Sometimes I think it's good, and then I'm worried that...
No.
But they're looking,
Yeah.
they're watching you, so that's
Thank you.
Okay.
Any other questions? By the way, I appreciate that the slides, well, from here are quite small, from back there are really small.
Oh, sorry. Yeah.
So they are available on our website, so you can...
Yeah.
You couldn't hear at all?
Okay, we've heard a lot about drugs. Is there anything you can say about immunotherapy, gene silencing that might help GIST patients for the future? Please.
Sure, that's a very interesting question. At the moment, we don't have data that immunotherapy or gene therapy is working. I'm sure that there are plenty of research groups that are working on this in the lab, but at the moment, we don't have anything clinical. It means no trials at this time, but we'll have more in the next years, not in the UK.
Is it that we're not having any trials on immunotherapy and gene therapy because there are commercial reasons behind why drug companies don't want that?
No, definitely
I
not.
tried to do a little bit of that before. When I first became involved in this, with this, I had an impression that, you know, let's be radical. My first thought was that drugs companies don't want to find a cure for cancer because they make so much money selling drugs to treat it, so they don't want to find a cure. That is absolutely, categorically not the case. Every drug company out there and every researcher is trying to find a cure for cancer. They will not, under any circumstances, commercially or otherwise, hold back on anything that they can or want to try in order to help the cancer community. And I'm talking about all cancers. So they won't deliberately hold something back for commercial reasons. That is one thing in all of my 10 years of being involved in this, speaking in depth, in detail, at length, with both drugs companies, with the NHS, right up to top-level government. We want to find a cure for cancer, and there will be no holding back in order to do that.
As far as immunotherapy is concerned with GIST, obviously I go to all the conferences, Europe, ESMO conference, etc. When immunotherapy first came on the scene, I thought this is it, I thought this is the answer. Subsequent to that, there were all sorts of studies, mainly in America, to look at how GIST might respond to immunotherapy. And the results that were coming out initially were quite disappointing because patients didn't seem to respond to the immunotherapy. Apparently there are some cancers that are like this. So obviously there's been quite a lot of work been going on to try and understand why that might be, what would actually make GIST cells amenable to immunotherapy. And there is a study, quite a lot of studies have been going on in Miami with Dr. Jonathan Trent and his team, and there's probably other doctors called Dr. Breelin Wilkie, because they're particularly focused on GIST and sarcoma, and they want to find an answer. So at the moment, up until now, there's been quite a lot of negativity or disappointment because immunotherapy hasn't appeared to work. And they're trying their best to try and find a way to make it work, but at the moment there isn't sufficient evidence, as we were advised just now, to actually bring it into the clinic and say yes, we're going to use it, because immunotherapy, isn't something which patients necessarily, the side effects of having an immunotherapy treatment are quite drastic, quite awful in some cases, and then when you've got through it, obviously, and it has benefited you, you perhaps don't need to be on any treatments anymore. It's been very effective in treatments for, I think it's melanoma, isn't it, some of the patients, but not all melanomas respond to it either. It's uncharted territory, and the researchers that are researching it need to get some answers that kind of make it more convincing to bring it any further. So there might not be something we can talk to you about it now, but it's not through lack of trying.
I just thought of another example of what I was saying about drug companies and the way that they're trying to solve the cancer problem. And a big thing that they're looking at the moment is what's called drug repurposing. Now that is where a cancer drug or a drug that has worked in one cancer, that cancer shows similar genetics to another cancer. It's already had approval to be used in the human body, so they try it on a trial basis on people with the other cancer to see if it also works there. An example that was found accidentally of that is imatinib. Imatinib was used in a different cancer, and it accidentally found it shrunk this other tumour in this lady's body that was a GIST. So drug repurposing is the way that the drug companies are trying to forward the use of drugs that have already been developed. And if you think about it, those drugs at that stage don't make any money for the drug companies anymore because they've already made their money. So if they had a view that, okay, well, let's concentrate on the ones that are making us money, they wouldn't be bothering with this. But they are, because they're trying to find a cure for cancer. So it's an important point to understand the myth that drug companies are only out there to make money. They're not. They're engaging with us, patient communities, a lot to see what we want, to see how we represent your views on cancer, including the views that we think that they're not doing enough. We tell them that, so they feed back to us how they are doing, what they're doing. They learn from us. So it's an important part of the process. There's another question over here.
Not a question, but a further response about immunotherapy. I think it's a mistake to focus on the fact that immunotherapy right now is not applicable to GIST. It's much broader than that. Look at it the other way around. There are in fact very few cancers for which immunotherapy at present is applicable. Yeah. However, immunotherapy is not just one thing. I've been seeing a lot of reports recently, news reports and journal articles, which describe new approaches to immunotherapy, using B-cell rather than T-cell immunotherapy. I saw an article last night which describes a process of using, of encouraging mutations of the cancer to create a vaccine specific to a person's own tumour, which potentially in the long run could assist immunotherapy for virtually any tumour. The point is that all of this research is in the very early stages. I'm convinced that given enough time, immunotherapy could well be applied to GIST. It's not only GIST that doesn't respond to immunotherapy. There's a lot happening outside the narrow field of GIST alone. Fair enough?
Fair enough, thank you.
Yeah.